A 30-year-old woman presents to her primary care physician for severe dizziness spells, and her dizziness is described as the room is spinning and it typically lasts a few minutes. Her symptoms are associated with nausea and ear ringing. At times, she feels like her left ear has decreased hearing and she denies any lightheadedness or palpitations. Physical examination is unremarkable. She is referred for audiometry testing and was urged to decrease her salt and caffeine intake. She is prescribed meclizine for symptomatic improvement. So this is a typical case of Meniere disease. So how did we how do we come to know this is a case of Meniere disease? She actually has you can see she is having dizziness, and then she even presented with ear ringing, which is tinnitus which is tinnitus and dizzy, spinning, room is spinning. What does it mean? It is actually vertigo, and she says she has decreased hearing in the left ear, so which is hearing loss. She denies any lightheadedness or palpitations. Actually, this sentence is ruling out something else, and then which is TIA, and then physical examination is unremarkable. She is referred for audiometric testing and was urged to decrease salt and caffeine intake. Okay, so to understand this a bit clearly, so we should understand the fluid mechanics behind Meniere's. So what is how what is the fluids which we can find inside the inner ear, and how are they regulated timely manner, and then what happens in the pathological state, and then we can understand why does vertigo, tinnitus and hearing loss is the clinical triad for Meniere's disease. So what really happens in the inner ear? So what we have is this is the bony labyrinth. This is the bony labyrinth, which is this is the bony labyrinth, and we have a membranous labyrinth over here. So membranous labyrinth is the one which is actually bony labyrinth is the one which is having the perilymph rich with sodium anion, and then we have endolymph which is rich with potassium. So the fluid secretion inside the membranous labyrinth is secreted by stria vascularis. Stria vascularis. This is the ultrafiltrate, and then and then it is the fluid is resorbed in the endolymphatic sac. So if we have in few cases like if there is an viral illness or autoimmune disease, or we have allergen of any sorts, and then it is not going to drain, and that causes the fluid to back up, and then there is going to be a build-up of fluid inside this membranous labyrinth. Now this membranous labyrinth is present both in semicircular canal and in the cochlea. So it is very easy to understand. If there is building up of pressure, we have dysfunctional cochlea. So we are not going to have the normal function of cochlea, which is hearing, and then we are not going to have the normal function of semicircular canals, which is normally the balance. So she might have vertigo, or one of the two presentations they might come to you is she might have vertigo or she might have nystagmus. So spinning of head is vertigo, spinning of eyes is nystagmus. If it is horizontal, it is horizontal nystagmus, If the eye movement is vertical, it is vertical nystagmus. That's how they are going to present to you. Now we will understand why does this happen, and then we will come to know why these patients are having this triad of symptoms in a typical case, and then we'll come to know what is the diagnostic modalities and so forth, the management. Now when to understand this Meniere disease actually happens in episodes. So my what I really mean by saying this is, so there is an episode which comes with this triad with subsequent resolution, and then there is another episode with this triad and subsequent resolution. Now if this is the case, how can fluid back up only during this period and not during the inter episodic period? So we will understand why this happens. So let's consider a typical case. If we have an viral illness, it is going to stop the endolymphatic drainage. It is going to stop the endolymphatic drainage. Then there is going to build up of fluid inside this. So and then it 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 is going to cause increased fluid inside the scala media, which is nothing but the membranous labyrinth. So if there is fluid accumulation in the scala media, then it is going to cause the tectorial membrane, which is present on the hair cells on the organ of corti, to hair cells and the organ of corti to depolarize, and then it is going to affect the hearing. Now this is because of increased buildup of fluid inside this chamber, which is scala media. Now it is going to accumulate with the due course of time, and then it is going to rupture this Reisner's membrane. So actually the Reisner's membrane is the one which is going to it is actually semi-permeable membrane. It is like one of those membrane which you see inside the egg, and it is going to separate to distinguish between the two different fluids, because the perilymph is rich in sodium ion, whereas the endolymph is rich in potassium. Now whenever that membrane ruptures, the perilymph is going to enter inside the scala media, and it is going to persistently depolarize hair cells, causing to fire the hair cells to a consistent period. So that is the result of tinnitus, and then that causes tinnitus. With the due course of time, this Reisner's membrane is going to heal off, and then the fluid is going to accumulate. It is going to resolve, and that is the time where we are going to have resolution in the inter-episodic period here, and then nothing happens here, and then once the backup of fluid happens, the same story goes on, so on and so forth. Now and then we have hearing loss, because as the tectorial membrane is persistently pressed on the hair cells, it is actually as similar to the strings of a guitar, where we are going to, when we speak up, the chain of ossicles are going to vibrate the this oval window, where the fluid vibration inside the bony labyrinth is going to travel inside scala vestibulae, and it is going to vibrate the resonance membrane and then tectoral membrane uh, in this pattern, and at a helicotrema it is going to be continuous with the scala tympani. Now this this perilymph this perilymph is actually is the one which is indirectly involved in the transmission of sound in the long term goal for any one of us in the normal case scenario. Now if you see what really happens in this case, the hearing loss which we get in the hearing loss which we get in Meniere's is actually low frequency hearing loss. Now why does it always should have low frequency hearing loss? To understand that, you should understand the frequency modulation in our cochlea will be normally ranging from 20 hertz to 20,000 hertz. So this is, let me tell you in simple words. So this is low frequency and this happens to be high frequency. Now this 20 hertz will be at the apex, at the apex which is helicotrema, the apex of the membranous labyrinth, and the 20,000 hertz will be at the base. So if I show you in a diagrammatic picture, then it would be, you will be understanding it in a clear manner. So you can see in this picture where here we can see 20 hertz at the helicotrema, and at the base you can see it is 20,000 hertz. Whenever there is fluid backup inside the membranous labyrinth due to endolymph accumulation, the first thing where the pressure gets affects the hair cells would be at the top, at the apex of the membranous labyrinth, and then because of this we are having low frequency hearing loss. With each episode we are going to affect all the subsequent hair cells, and ultimately we are going to ultimately end up having high frequency hearing loss also. So that explains why we have hearing loss, that too frequently in the low frequency. And then why do we have tinnitus? Because of persistent depolarization of the hair cells, because of anions exchange due to the rupture of resonance membrane. And the third thing which we should understand is the vertigo. It is not difficult to understand vertigo, because as membranous labyrinth is expanded not only in cochlea but even in the semicircular canal. So if we understand semicircular canal, so semicircular canals have this membranous labyrinth, and whenever fluid backs up, even this causes the macula to dysfunction improperly and function improperly. And then the function of semicircular canals is to maintain balance, so which is not happening as such in this case. So we are going to get vertigo. So they are going to have the feeling of nausea, which we can see in this case. And then because they are feeling this is actually peripheral vertigo. Now because the pathology is happening inside the inner ear than at the level of central nervous system, so this is a peripheral vertigo. To be in specific, this is a peripheral vertigo. And then there are many other cases where we should rule out, but by far we are not going to discuss now. And these three triad are going to present in an episode, and then we have normal resolution. So when a patient gets these three complaints, and then when he visits your clinic, where he doesn't have any of these symptoms, then the audiometric test is not going to show anything. But when the symptoms are again when it again starts up, and then when you do an audiometry, you are going to find the audiometry is going to only find uh, the only frequencies, whether both the ears are having normal frequencies or not. As we have discussed, we are going to have initially low frequency hearing loss because the pressure buildup happens at the apex, and then it is going to back up the fluid and ultimately resulting in high frequency hearing loss at the long term goal. Now, now what is the diagnostic modality for Meniere's? Meniere's disease actually, for per se, is a clinical diagnosis. We are not going to do any diagnostic modality, but we are going to do many for typical symptoms. We are going to conduct a pure tone audiometry, so which is going to show some of the important findings as we discussed previously. So the apex is affected due to the pressure buildup. So low frequencies are affected. So you can see here we have to understand this. It is very simple. So we have two things. We have a circle and we have a box. So the box will be for the left ear and the circle is for the right. So you can see this female patient has left ear. She has decrease here in the left ear. So left is box, and the left box at the lower frequencies are affected. So you can see 125 250 is reduced, and then the higher frequencies you can see it is matching with the normal graph. So it makes sense. So it has affected till 2000. Below this we have decreased hearing loss for the lower frequencies. So other way of saying, we have affected frequencies at the apex, and then it is progressing towards the higher frequencies. So this is one of the diagnostic modality. We have other tests for doing atypical symptoms like vestibular functioning test, rotatory chair test we have, and then electronystagmogram we have, which we in this we are not going to do in this due course of time in the present situation. And then you can see the physical examination. In atypical symptoms we are going to find nystagmus, but if it is very rare nystagmus cases which is associated with Meniere's, but you can see the physical examination apart from that seems to be normal, and she in this case she has been advised to have less salt and caffeine intake. So the whole purpose of this, why did physicians said this, is to decrease the fluid inside the endolymph, and therefore the fluid inside the endolymph will be reduced production, thereby decreasing the pressure inside the endolymph. So and then the other thing we are going to give is two things are affected. So vestibular suppressants, which is benzodiazepines, and then the other thing we have is or we can give and first generation histamines, which is we can see it is already given to her, which is metrizine. For vertigo, the most common drugs for vertigo will be first generation antihistamines. And then we have something or we are going to do chemical labyrinthectomy by injecting intratympanic membrane approach by injecting gentamicin. So you can see transmembrane injection. So you can see transmembrane injection of gentamicin, which is going to chemically ablate the vestibular nerve, and thereby she can have resolution of symptoms. The other moderate thing which we these days are being done is some vestibular rehabilitation exercises. One of the famous ones are banded dare of exercise, and I'm going to play one of those exercises, the famous ones, and then this is going to reposition the semicircular canals with the fluid mechanics, and then they are going to have a better relief during the episode of Meniere's.
Sitting on a firm flat surface, turn your head towards one shoulder and lie on the opposite shoulder. The nose should be pointing up at a 45-degree angle. Remain in this position for about 30 seconds or until vertigo subsides, whichever is longer, and then move back to the seated position. Repeat the same maneuver on the other side.
Yes, she is going to reposition her head, tilting 90 degrees up the roof, and then only twisting her shoulders, and then doing on the same thing on the other side. So this is Meniere's disease. This is the overview to understand what is actually happening, and then which frequencies are really affected in Meniere's, and what is the management, including diagnostic modality we do for Meniere's, and management and the treatment for Meniere's, which is vestibular depressants like benzodiazepines, and first generation antihistaminics, or chemical ablation by giving gentamicin injection, which is actually a side effect of gentamicin, because aminoglycosides have vestibulotoxic effect. And then we are having vestibular rehabilitation maneuvers, so of which we just played branded dare of exercise, and the other thing is to or we have something called as endolymph decompression surgeries. So